Thank you all very much. It's really a joy and an honor to be here with you. I see a few familiar faces among you and look forward to meeting more of you in the course of the evening. My plan is to address the subject for probably a little less than an hour, and then we'll have time for any questions and discussion that you'd like to engage in when we finish with that. I'm going to divide my remarks into 4 segments. I want to just offer a few personal reflections at the beginning. Then I want to talk about the present state of affairs in healthcare in the United States especially. Then I want to move from that into this issue as a religious, moral issue, which I think is the central concern that you asked me to address. And finally, I want to say a little bit about what seems to be happening right now in the public policy arena, although it's still a bit of a guessing game. But just as sort of some personal comments to begin with, when I finished that doctorate in 1972, I thought I would be teaching fundamental Christian ethics for a long period of years. But within just a few years of that time, I was invited to become involved as an ethics consultant for a number of hospitals, Catholic hospitals especially. And when I was first drawn into ethical concerns at Catholic hospitals, it was mostly on end-of-life care issues, questions of withholding feeding tubes or not resuscitating people who have cardiac arrests and things like that. And I worked on those questions for a number of years, and I don't want to dismiss those questions at all because I think they are important questions, and I think we all need to make good decisions about end-of-life care. But it didn't take very long for me once I began to be connected with health care on such a frequent basis. It didn't take very long for me to realize that the deepest ethical and moral question in health care was much more profound than simply these questions about individual decisions on care at the end of life. I became quickly aware that the deepest question was the question of social justice, the question of how to achieve justice in the delivery of health care. So by the end of the 1980s, I was really focused on that, and as the introduction mentioned, I've published 2 books already on that set of issues, and I have a 3rd book that's just about ready to go to the publisher, which is on the way that the advancing research into human stem cells ties in with the questions of social justice and the delivery of health care. I don't know if you're aware, just briefly, that according to a decision of the United States Supreme Court, stem cells are a commodity that can be owned, bought, and sold, and the fact is that all of the stem cells that have currently been legitimized for use in the United States are in fact owned, patented by the University of Wisconsin, and they are charging everybody to use these stem cells to do research on them. And I just think there's enormous ethical questions wrapped up in that, and they tie right in with the idea of healthcare as an economic commodity that can be bought and sold, and I think that is the underlying question that has given us so many problems as far as healthcare justice is concerned. So that's kind of where I have come, and I just wanted to mention that briefly. But my second point really then is just to take a few moments to talk about the scope of the problem. I mean, I think we all know that access to health care is an enormous problem in our country, but I think it's important that we just be a little bit clear on some of the details. Every year in the month of October, the Census Bureau publishes its annual estimate of the number of people in the United States who do not have health insurance in that particular year that they're reporting on. And for the last several years, these numbers are running between 45 and 50 million people on any given day in the United States that do not have health care insurance, any kind of health care coverage. It doesn't mean that they are totally without access to health care, because there is charity care and the things that emergency rooms do and so on. But there's no question but that in my mind, but that not having insurance makes one wait longer to seek health care, makes one get sicker before one seeks health care, and contribute greatly to the problem. I'd also want to say to you that that number of 46, 47, 48 million people without health insurance has been increasing steadily over the last couple of decades. It's not like it's a fixed number. When I first started tracking this with some seriousness 15 to 20 years ago, the number was more like 35, 36 million. So you see it continues to go up on an annual basis, and the problem just seems to get worse and worse as the years go by. I think also that it's significant to realize that the number 46 million really doesn't capture the depth of the problem of access. Besides the 46 million people who the Census Bureau would name without being uninsured, there's another segment of our population, roughly 30 to 35 million persons, who have health insurance today, but if the present system continues, will be without health insurance at some point during the next 2 years. Due to job losses, arbitrary cutoffs by insurance companies and other things, there's the whole question of this being a rolling issue, if you will, and persons who may have coverage today, but who are nonetheless at risk of being without coverage at some time during the next 2 calendar years. And then in addition to that, we have that segment of our people who have health insurance, but whose coverage really isn't adequate to meet their needs. So while they're officially listed as being covered, the coverage really isn't suitable to take care of them. This is the group that are known as the underinsured, and there's another 30 million or so of those folks. So if you add all of these numbers up, the 46 million persons without health insurance today in our country, the 30 million or so that are at risk of being without health insurance over the next couple of years, and the 30 million whose coverage simply is not adequate to meet their needs, you get up to roughly 105 million persons altogether in our country for whom access to health care is a very, very grave crisis. And just to amplify that a little bit further, if you consider that because of Medicare, and I'll say more about Medicare later on this evening, because of Medicare, virtually everyone like me in the United States, everyone who's 65 and older, is considered to be insured, you see, because of the existence of Medicare. So we have 300 million people roughly in our country. But if you subtract the 75, 80 million people who are the over 65 persons, maybe it's a little less than that, you're getting down to 225, 230 million people 65 years of age and under. And then if you consider that there's 100 or 110 million people for whom access to health care is a real threat because either they don't have it or won't have it, we're getting up to fairly close to half of the U.S. population under 65 for whom this is a crisis, you see. So I think we really need to understand the magnitude of this issue. And I just doubt very much if there's anybody here tonight who doesn't know numbers of people for whom access to health care is a crisis in their lives as far as that's concerned. So I think we need to look at those numbers just to understand the magnitude of this problem. But the numbers, as important as they are and as staggering as they are, the numbers themselves aren't enough until we think a little further. If you look at the persons who are uninsured, it's true that the biggest single component amongst them are people in their 20s. And of course, a lot of them are persons who have come off of their parents' policies, and they think they're immortal anyway, and they don't think they're going to have to worry about it. So you can sort of understand why it is that there's so many persons in their 20s who lack insurance. But the statistics tell us that the second most likely group in our country to lack health insurance are children, particularly children of single mothers, as far as that's concerned. And it's true that we have seen the passage in the last couple of administrations of these CHIPS programs, Children's Health Insurance Programs, and no doubt they've helped cover more children than would have been covered otherwise. But the total number of children without health care continues to increase, even in spite of CHIPS. So I think that that's a very sobering part of the reality. And then the third most likely group to lack coverage are people between 55 and 64. In other words, people just short of the age when Medicare kicks in. And this is an age group in which significant health care problems often ensue. And of course, I think you can understand why they would be in the group as much as they are of the uninsured. They can lose jobs, and if they lose jobs, it's hard, and we're seeing so much of that right now, it's hard for them to find new jobs sometimes because of their age. So they're a vulnerable segment of the population that are clearly at risk. So you've got all of those factors to remind us what an enormous problem this is. But there's some other things that we should consider as well, just to realize the scope of this problem. We spend in the United States more dollars per person than any other country in the world about health care. We spend about half again as much on health care as any other country in the world. Roughly $1 out of every 6 in the United States of economic activity is a health care dollar. It's a sixth of the gross domestic product of the United States. Other countries that we are friendly with, connected with, like Canada and Japan, the United Kingdom, are all spending about 10% of their gross domestic product on health care. So we're spending half again as much. And yet our results are demonstrably poorer. In spite of the huge amounts of resources we pour into health care, if you take basic public health statistics, the United States is shockingly behind most of the other countries in the developed world. You look at something like life expectancy, for instance, how long people live. All of the Western European countries, Canada, Japan, virtually all of the other highly developed economies in the world, people live on average several years longer than they live in the United States. It's true in our country that if you subtract from the U.S. population persons of African American origin and Hispanic Caucasians, and you only look at non-Hispanic Caucasians, the life expectancy of non-Hispanic Caucasians is closer to the European countries than is the population of the U.S. as a whole. But even our non-Hispanic Caucasians have a lower life expectancy than do people in all of these other countries. And then you can talk about, there's a lot of these statistics that we could talk about. Immunization against childhood diseases, we've improved in that regard, but we still fall behind many other countries. And then there's the whole thing about infant mortality. There are 36 countries in the world, roughly, where a baby is more likely to make it to its first birthday than in the United States of America. And this in spite of the fact of our having the most incredible neonatal technologies in the world when you come right down to it. And I see these high-tech neonatal units in our great hospitals that can do fabulous things. But although we focused on that end, it's obvious that we do much more poorly, or at least significantly more poorly than many other countries in terms of providing basic prenatal care and postnatal care to poor women and their children. I mean, the fact that so many countries in the world are more successful in getting babies through the first year of life than we are in this country, I just think it is a great moral outrage when you come right down to it. And we have all the development in our country of things like test tube babies and so on, and I don't want to say that these things are necessarily bad, but yet when we spend vast sums of money to develop those kinds of technologies and we're not providing basic prenatal and postnatal care to poor women and their children, it's hard not to come to the conclusion that something is terribly wrong. So I just wanted to underline these issues. We could also talk about the impact of the fact that we spend so much more money than other countries with demonstrably poorer results in terms of public health measures. We could also talk about that in terms of its negative effects on economic life in our country and therefore on the broader quality of life in our country. The fact that we do this, spend all this money, creates great stress for businesses in terms of the enormous cost for health insurance for those who do provide it. And then we can talk about the chaos of our system and the vast sums of money are spent in terms of its depressing effect on other segments of our common life together. In 1970, in the United States, we spent roughly the same amount of our gross domestic product on education as we did on health care. Health care is now taking up about 3 times as much of our gross domestic product as education is. And you could say this about other human goods too. The more money that gets sucked into health care and sometimes spent inefficiently, if you compare our results with other countries, the less we have for other human goods. I mean, one of my fantasies is that we'll still continue to develop these incredible new medical technologies as we move into the first century of the new millennium, but that our educational system in our cities will break down so badly that by the middle of this new century, we'll have nobody who's literate enough to use the new medical technologies, and then what good will they do us? That's maybe a bit of an overstatement, but I think you can see that we need to look at this social good in the way it interfaces with all the other human goods that we need to be concerned about as a people. Obviously, there's much more that I could say about this side of the issue, but I simply wanted to take the time I've taken so far just to outline what a huge problem we're talking about here. And this leads me to the next and probably the most substantial or significant part of my remarks. I realize that this question of the delivery of health care surely has economic components and that we need economic policymakers to help us figure it out. And I realize as well that it's surely an issue for politicians and for public policy. And I have no objection at all to the involvement of politicians, the involvement of economists in the dialogue about reforming health care in the United States. But as far as I'm concerned, and I feel this very passionately, it's simply not enough to leave this to the politicians and the economists. I think it's crucially significant that we grasp this issue as a religious moral issue, see it as a challenge of faith, a challenge of moral living, that we look at the issue this way and say that access to a decent level of health care simply is a matter of morality. It's a matter of faith. It's something we owe to our citizenry as a moral people, a people of faith. And what I want to do is simply try to unpack this statement that I've just made, that this issue, for all of its political and economic dimensions, that in the end, this issue is ultimately a moral issue and even a religious issue. And as I do the unpacking, I have to admit that I'll draw a lot from Catholic sources, since there's so much in my background, but I will try to connect with some of the other Christian sources, Protestant sources as well. I mean, I have to say that on my own intellectual journey, besides the great Catholic theologian Karl Rahner, on whom I did my dissertation, I think there's no doubt but that the American, other than Rahner, the American Protestant theologian Reinhold Niebuhr is the single most important person I've ever read, and so I think we need to do this in an ecumenical fashion, and I respect that very much. But I do come at it out of my own particular awareness. And there's several different themes I'd like to comment on to help focus the idea that this is a moral issue. First of all, to say something about the meaning of justice and what justice really calls us to. Tim and I were talking at dinner tonight about how enormously individualistic our society is. I think this is one of the great problems and challenges of American life at this time, that we are such a nation of individuals rather than a community. And because of that individualism, when we hear the word justice in our particular culture, we often think about relations between individuals, as far as that part of it's concerned. And there are issues of justice in relations between individuals. Besides climbing mountains and cross-country skiing and stuff like that, I like to bicycle, and I have 2 or 3 bicycles. And if I decided to sell one of my bicycles to you for $50, to one of you here in the audience, and you give me the $50, I got to give you the bicycle. I mean, that's justice between individuals. A deal is a deal. But I think that for a lot of us, when in our culture at least, when we hear the term justice, this is our primary model of reflection: contracts, business relations between individuals. And I don't want to set that aside, but if we look at the great theological tradition of the churches, it's clear that justice goes far deeper than that. If we look at the biblical concept of justice, justice has to do with the whole of the society, with the well-working of the society. And perhaps at the deepest level, justice refers to the obligation of a society to be sure that a reasonable level of basic human goods is there for everybody. That's the most profound notion of justice to me, often called by some of the medieval scholars distributive justice. That society has the responsibility to be sure that a reasonable level of fundamental human goods is available to all persons. It doesn't say that society has to do all of this through public activity. If some phases of a just society can be accomplished on a voluntary basis, that's acceptable. But if that doesn't happen, then the public policy level of justice needs to kick in. That's for sure. But can we have a sense then that fundamentally access to health care involves this basic claim of justice? And I also have this to say, that if this is what justice calls us to build a society in which all people have access to fundamental human goods, a corollary of that where it comes under such criticism in our society today, a corollary of the fact that society has this responsibility to provide means of access to fundamental human goods. A corollary of this is that taxes are okay. I'm not saying that every tax is okay or that every specific tax policy is as fair and just as it should be. But if we talk about the larger role of society in ensuring true social justice, it's inevitable that there have to be tax policies in order for that to happen. And to say that taxes are in principle bad or in principle wrong simply isn't acceptable. Surely you can criticize individual taxation policies and ask whether this is the fairest way to do it or not. That question remains on the table. But if we talk about distributive justice and we talk about the need of society to assure that in some way fundamental human goods are there for all people, the implication of that is that reasonable tax policies are part of what we would expect in a just society. Moving from justice, the second great theme in Christian social ethics that I want to highlight for a few minutes that I think is so important for us to articulate in the context of healthcare reform is the theme of human rights and of healthcare and access to a reasonable level of healthcare as a fundamental human right. The earliest thinking about human rights in the modern era, anyway, dates from the late 18th century, from the U.S. Declaration of Independence and the French Declaration of the Rights of Man, and then the Bill of Rights, as far as that's concerned, of our Constitution. In those documents from the last years of the 18th century, the focus on rights was kind of an individualist, don't bother me focus. Leave me alone so I can do what I want, so that I can practice my religion, say what I want, bear my arms, get together with my friends, and so on. The individualist, sort of a non-interference vision of human rights was the first thing that we saw in modern human rights thinking. And I don't want to say that that's completely wrong, but it's obviously much too narrow of an understanding of human rights. I mean, when you hear somebody get up and say to a group, "I demand my rights," you can almost hear them saying, "The hell with everybody else." You know what I mean? That's the problem, I think, with making it too individualistic. And as we got into the latter half of the 19th century and into the 20th century, we began to see in the writers and theologians of this period a much more social understanding of human rights, an understanding kind of allied with what I said a few moments ago about distributive justice, an understanding that our call is to provide a level of basic human goods to all people. I mean, I think of Pope Leo XIII and the first great social encyclical in the Catholic Church, Rerum Novarum, from 1891, in his insistence that all people had a right to earn a living wage, to earn enough to live in reasonable and frugal comfort. Our present minimum wage legislation in the United States in no way approaches a living wage as far as I'm concerned. That's another whole set of issues. But so you see, this is a kind of a broader concept of rights, the concept that society needs to create those conditions in which not only are people protected from others interfering with them, but people's situation is positively enhanced in terms of access to fundamental human goods. It's in that context, this sort of social notion of human rights, that I think it makes complete sense to talk about access to health care as a human rights issue. By the way, just as a very brief aside, I mentioned Pope Leo XIII, and I'll take a minute to tell you one of my favorite theological funnies for just very quickly. When Pope Pius IX died in 1878, there was a lot of uncertainty amongst the Catholic cardinals about who they should elect to succeed him. It was a very tumultuous time in Europe. The Franco-Prussian War had just happened, and there had been all sorts of other upheaval in the middle of the 19th century. There was this older cardinal by the name of Joachim Pecci. In his late 60s, he'd been Archbishop of Perugia for 32 years. He was out there in Perugia reading about social justice, except none of them knew that. He was very frail. He had a couple heart attacks and a stroke. He was walking around the conclave with a limp. The cardinals were quite uncertain about what to do, and they said, "Let's elect Pecci, because he'll die in a couple of years, and then we can figure out who we really want." Well, I'm here to tell you that he was elected as Leo XIII. He lived into his mid-90s. He buried every cardinal in the room. He was the longest single survivor of the group who elected him. It's the one and only time that's happened in the entire history of the papacy, as far as we know. When John Paul II, who was Pope for so long, died 4 years ago, there were still 3 electors who had been voting for him who voted for his successor in 2005. But Leo XIII had a clean sweep. They were all dead and gone before him. But he became a very important figure in terms of his commitment to social justice, to modern study of Scripture, modern study of philosophy, and so many other issues as well. Now, in talking about the human rights question here, you might notice that in the earlier writing about social rights from the late 19th and early 20th century, nobody said much about health care as a human right. And maybe you're asking, why is that? Why wasn't this theme emphasized more in the last years of the 19th and first years of the 20th century? I think the basic answer is because back then, health care was so primitive. Even in the developed countries like the United States, life expectancy was 43, 44 years. Doctors didn't have very much they could do to help people. They were looked on as an underclass in society, often made less than the farmers that they cared for. It was only in the latter years of the 19th century, with the discovery of things like anesthesia and effective sepsis, that healthcare began to make the enormous leaps forward that it has made over the last 100 or 120 years, and we've seen life expectancy in the developed countries not double, but almost double from what it was a century ago. So I think that explains why there just wasn't much thought about healthcare as a human right in this earlier period. By the way, I can tell you, because of where I live, that the first medical school in the United States ever to set a quota to keep women out was in fact Johns Hopkins in Baltimore, and it was precisely in this period in the latter years of the 19th century when these medical discoveries were made, and some of the guys began to say, aha, this is going to be a lucrative, productive business after all, unlike what it used to be, therefore it's time to keep the women out, so all these things tie together in various ways as far as I'm concerned. I can tell you that the first president of the United States to mention health care as a human right was in fact Franklin Delano Roosevelt in an address he gave during the Second World War. The first Catholic Pope ever to cite health care as a fundamental human right was John the 23rd at the beginning of the 1960s. So you see, these assertions about health care as a human right, which I think are so pertinent today, really come 50 years after the social rights thinking that emerged in the late 19th century. And the third great theological theme that I want to highlight in talking about this as a religious moral issue is the whole concept of the common good. The idea that somehow it's for all of us that we need a just health care system. And the idea that if my health care is fine in terms of access, it doesn't matter about the other person. That simply doesn't work. When you have a theology of the common good, you have to be focused on society as a whole. And you have to be able to say that all citizens need to come together to support the good of each citizen. And the idea that some young people are saying today, I'm healthy, why should I have to have health care insurance and help pay for the older people? First of all, young people do get sick, and if they do get sick, they often get tragically and catastrophically sick as far as that part of it is concerned, and with enormous expense. And in addition, just the social notion that every one of us has an interest in good health care for every other one of us, regardless of our personal circumstances. That's what the common good is about. And I think the notion that this is a matter of the common good becomes all the more huge, in my view, if we stretch ourselves out to a global perspective. And if we consider that there are still countries in the world where life expectancy is only in the 30s. The Sulpicians, the community that I belong to, our province here in the United States, about 20-some years ago now, took responsibility for the Catholic seminary system in Zambia in southern Africa. And I've had a chance to go there a few times because of being involved in leadership for our group. And in that country, Zambia, and in several countries near it, Zimbabwe, which is such a frightening place, Malawi, Swaziland, and there's one other that I'm forgetting, life expectancy in all of those countries is down to about 36 years of age. And it's better in other parts of Africa, but nowhere that I'm aware of until you get very far north in Africa does it get beyond the mid-40s. And it just seems to me that if we're going to have a globe in which there are places in the world where young people look at their future and see that they're only going to live half as long as people live in places like the United States or Western Europe, it just seems to me that that is a formula for ongoing instability, globally speaking, ongoing military actions, ongoing warfare, and it seems to me that in the deepest sense of the common good, that just delivery of health care on a global basis really is an issue that's necessary for the future peace and stability of the world. I think we've got to think in that broad a category. So I've highlighted these three great themes, social justice, human rights, common good. But I want to mention a few other things more quickly, not as significant, but still deserving of mention. I want to say, for instance, that as far as a Christian theological view is concerned, there is no one economic system that is the way in which goods of the world should be delivered. Here in the United States, there are some who seem to take the stance that free market economy is an act of God. That is not what theology says. The theological viewpoint is that property has both individual purposes and social purposes. And while it's true that when modern socialism began to come on the scene in writings of Marx and people like that, there was so much atheism connected with it that there was a lot of critique of socialism. But really, as far back as the time of the Great Depression in the end of the 20s and beginning of the 30s, theologians began to make distinctions between atheism as linked to socialism and socialism as a theory of economic distribution. And as far as I understand theology, the question to be asked is which particular economic system can do the most for a given society at a given point in human history. That's the question that theology wants to know. What can do the people the most good? If in a given place in history, in a given culture and locale, a capitalist economy can work the best for everybody's good, all well and good. But if in another society, in another set of circumstances, a socialist economy can work the best, also all well and good. What meets the demands of justice, in other words? That's the fundamental economic question from the Christian perspective. And in the final analysis, it may well be that the best answer in terms of economic justice is going to be a mixed type of economy that has some socialization of some aspects of an economy and a private enterprise approach to other aspects. But as I say, we do hear capitalist economics presented as an article of faith by some in our country. I think a theological vision is more sophisticated than that. There's also a lot of discussion about the attractiveness of doing things in the simplest way possible and with the least amount of government intervention possible. I surely understand that issue. But as corporations become bigger and bigger, and we are in this age of multinational corporations, I think it's clear that more and more of the goods of society are going to need to be managed on a socialized basis than was the case in simpler economic times. Maybe we might wish that wasn't the case, but I think it's hard to escape it. I also wanted to mention quickly, and this is more to the specifics of the legislation, that I think any reasonable theological perspective would hold that there are difficult and complicated decisions to be made at the end of life about which technological interventions might benefit a person and which not. And I know that families and doctors struggle greatly over these questions. And I think that unless we're talking about a technology that simply doesn't work and simply won't accomplish anything, there needs to be that dialogue between patients and physicians and families, and people need to be having the freedom to make the best judgments that they can. But I just think that this is a complicated, difficult part of the healthcare world, and to the extent that some of the current healthcare proposals would try to facilitate discussion and reflection on those issues, I think that's for the good, because people do struggle with these issues. And from my viewpoint, and maybe I'm being too blunt here, but this death squad attack that we heard during the summer was utter nonsense as far as I was concerned, because there is the need for sober, thoughtful reflection on these issues. Also, just to say something very quickly about abortion as it relates to health care reform. I recognize there are different views on this subject, and I respect that. But what I want to talk about is the situation for those churches that are opposed to abortion and how that plays out in an issue like health care reform. And what I would say is this, that if we read great theological minds, again going back for centuries and centuries, there's always been the understanding that we need to make some distinctions between moral convictions and public policy, and that public policy is a complex reality that may not always be able to embrace all of one's moral positions, and that sometimes one has to make the best judgments that one can about what a good public policy would be. Sometimes one accepts a public policy in good faith, even if that public policy doesn't fully embrace everything that the individual might believe in or hope for. And I think the Catholic bishops as a body deserve credit on this issue for saying that they realize that it simply isn't to be understood that a change in health care reform would eliminate abortion in the United States. What they've said, in other words, is that they would hope that it would be negotiated in such a way that it doesn't enhance abortion further. You know, that they've talked about wanting to have it be abortion neutral. I think that's clearly an example of where you've got a moral conviction, but you know that a public policy can't completely embrace your moral conviction, and you try to make the best judgment that you can. And it's from what I've heard in the last 2 or 3 days, the House of Representatives seems to have worked out some language on this particular issue to go into the bill that they may vote on as early as Saturday, which ostensibly will keep all sides happy. I gather there were about 40 of the Democrats in Nancy Pelosi's coalition who wanted language that was more clear about not further enhancing access to abortion, and apparently some language has been worked out. But that's a long-standing notion that in public policy you're concerned about its moral content, but you have to make judgments on it in a realistic, pragmatic way. Okay. If it's a religious moral issue, which I clearly think it is, what to say about where we are right now and what's going to happen? And I don't know the answer, of course, but I'd like to just articulate this, that as I look at the whole question of the lack of access to health care in our country and the need for reform, at the theoretical level, I think there are 3 possibilities. One possibility would be to do something like our friends in the United Kingdom do, and to see the government actually go into the healthcare business, so that the government hires doctors, builds hospitals, runs the healthcare system itself. That's socialized medicine in the strong sense, if you will, where the government not only becomes the financer, the insurer, but the government actually is the deliverer of health care. No one has seriously advocated that in the United States. And as close as we are to a country like the UK, I think it's fair to say that that type of an approach, the strong socialized medicine, probably would not work in the United States. The option at the opposite end of the spectrum is the opposite of private reform, letting the healthcare system, with the aid of government regulations, manage itself, continue to be a private, separately operated, separately funded system, but with enough government regulation so that there will be better access to health care. I really understand how attractive this idea is in the United States. Leave the private system of delivery and insurance in place, but regulate it so that it becomes more just. I really understand how attractive that is in our country because of our commitment to a free market type of economics. But I also have to tell you that after studying this and thinking about it, reading about it, writing about it for the last 20 years, I have a lot of doubt, as to whether this can really work, whether even with a much more regulated environment, the good of health care can be made to be like another economic good. I just don't know that it can, and I've sat on enough boards of trustees in healthcare settings to know that the business model is very strong, and I'm not at all sure that even a heavily regulated private delivery system would break us out of this. And that leads, of course, to the third general option, which is a system in which the government becomes the insurer, the financer of health care, but the actual delivery remains in private hands. So the hospitals remain private entities owned by foundations or universities or religious communities. The doctors remain independent persons, but that everybody in the country is insured on a national basis. That is, in fact, what Medicare is. In Medicare, you still go to your private doctor and you go to the hospital that you choose to go to, but you're covered through a unified national insurance system. And all the healthcare economists who study these issues in our country will argue that Medicare is the single most efficient part of the healthcare delivery system in the United States when you come right down to it. And of course, it was so funny this summer during the month of August and all these protests. I don't want any government-run program, but don't you touch my Medicare. I heard that on television again and again. Well, I'm here to tell you that Medicare is a government-run program, and it works pretty well. So it's hard for me not to think that long-term, something like a Medicare system for all citizens isn't where we might have to go. Currently, what the Obama administration and the majority in Congress seems to want to do is to try to combine the second and third things I just talked about, to leave the private delivery system and private insurance system largely in place, but with regulations to hopefully make it work better and more justly, but to supplement it with some sort of a public system, the so-called public option, the idea being that if there is a publicly financed option, that'll force the insurance companies to behave better. I think, first of all, it remains to be seen whether what passes actually will include a public option, although I think it would be good if it did. And I also think it remains to be seen whether a relatively thin public option with the private system left largely in place, although more regulated, really will serve the demands of justice. If that's what happens, it's hard for me to wonder if in another 10 or 15 years we won't have to revisit the whole thing again and have another debate and finally face the fact that something like Medicare may be the ultimate answer. I really do profoundly hope that something, no matter however imperfect it is, actually passes in the next several months. It now looks like, based on what Harry Reid said, that we might be going into the month of January before we see the Senate actually voting on it. But I think getting something passed will be a hugely significant step, at least be a good beginning. But for the reasons that I've just said, I think we'll also have to carefully evaluate and assess what has passed in the first years of its operation to see how effective it is or it isn't. And if a private reform with more regulation succeeds, or if a private reform with more regulation and a thin public option succeeds, I'd be delighted. But I'm not really sure whether that will happen. But if we at least pass something, I think we'll be started in the right direction. And if all of you can simply make it so clear to everybody you talk to that this is a matter of moral responsibility for committed, believing people, and not simply a matter of economics and politics, I think we can take the whole process a long ways forward. That's a lot in a short time, but thanks very much.